Thanks, Steve, for being willing
No
to be interviewed. Could you tell us a tiny bit about your research background?
I suppose I've been doing research for most of my career, but I don't have a research background. I don't have research training. I trained as an occupational psychologist first, and worked for BP for a while. Found that I hated that, and then fell into clinical psychology, and on the suggestion of somebody, and did that training, and then I went into a full-time job in the NHS. It's fair to say that I've always been interested in research and understanding why, and trying to apply methods to understand things, but I don't really have a formal research training. So
you've done the DClin, but not a PhD?
Yes, yeah. But I've been around people who have research training, I suppose, and kind of learn a lot from them as I've gone along. But I wouldn't describe myself as a researcher, though I do some research.
So tell us a bit about the kind of research you've managed to do in that routine clinical setting, and then since also getting into a kind of training university role.
So like a vast range, really. Kind of, I've always been interested in kind of single case experimental design, but also doing. So the first part of my career was in routine practice and leading a enduring mental health kind of psychological therapy service, and we used to kind of house. Devise and house small trials and try to make use of what was going on clinically anyway, but just use a bit of a method to applying it to it. So doing like following people up regularly and stuff like that, or thinking maybe we can devise a better way of allocating people to these people to groups or something like that, and then devising a method that would kind of fit around that. But always having a kind of an eye on, this is pretty small scale stuff. We're not going to devise and conduct the definitive study in this. It's just it will make a contribution. And it was a way of keeping staff engaged, keeping me engaged, and I think it was useful organisationally as well, because that our department got known before outcome evaluation was a thing, is a thing in the NHS. It was known as a department that was kind of outcome friendly and stuff like that.
So it sounds like you were hanging your research around the routine clinical business you were doing, but bringing a bit more methodological rigour to it.
Yeah.
And having a view to, is some of that worth writing up and publishing?
Yeah. But having quite achievable projects, small goals, and very much a kind of emphasis on people working together to do this, and people having different expertise and stuff like that. So, and I think there was something about, if there was in a sense, a kind of routine problem, like a waiting list. It was like, okay, can we do something about the waiting list? But whilst we're doing something about a waiting list, create a project out of it. So I remember going to see Jim White talk about his stress control stuff. Spoke to the woman who was the lead in primary care, and I was like, have you seen all this stuff? Go and talk to him. And out of that, because we used to get a lot of transfer from primary care to secondary care, I was a bit like, well, can we do something kind of, very early down the line? So we housed a very early trial of the stress control stuff, and that was purely around the business plan for the organisation. So it was a bit like, if I could see an opportunity in terms of routine practice of a problem that we could try to solve, but apply a method to it, or I could see something in the business plan which was, kind of a kind of objective or goal of the managers, then we could often collaborate, and the managers would be kind of fully behind what we were doing.
So a lot of people who run trials would say you need £2 million and a massive research team to do it, and you've done this kind of stuff without blue chip funding. So how have you resourced it?
Well, that's a good question. So I think the answer is that I've always had access to kind of assistant psychology time, and also using volunteers as well. People will say, can I come in? And it's like, yeah, come and work for the summer, but these are going to be your tasks and so on. Also putting some of the ways in which you make decisions in research projects a routine aspect of people's work, and so on. So, but we've never had a large amount of money. So we ran a trial in assertive outreach, and it was a pilot trial, kind of 12 clients in each arm, and so on. But that was from a pump priming grant, which was £5,000, which was for ages the most amount of money I've ever won. But it was a bit like, right, we'll do this, because the team, in a sense, were kind of calling out for this, and it was a trial based on trying to help them to work better with their clients. So it was like people were on board with it, the management were on board with it. We applied in a kind of 2-page pump priming. There's a bit of money going to do this stuff, and got it. And then it's kind of trying to wring as much out of the money as possible. So in that money, there's not money for visiting a colleague in Zurich or in that blue chip stuff, which is fantastic kind of thing. And I think that's what produces this really high quality research. But it's a kind of more smaller scale, often pilot, often feasibility, but with methodology applied, and then squeezing the pips of the money.
To really focus on the key deliverables, not the fancy bells and whistles around the edges.
And it's always a team approach. So it's not me. So it's me and a range of people, and I think that helps to build relationships with people, and also maintain relationships with people a little bit, and having a common goal, I think, is a really good thing. So, and normal team stuff like, celebrate when you get something accepted, then you all go out for dinner and you all celebrate, stuff like that. So, and I think there's also something about learning as you go along, that you do one study, probably in a kind of okay way, and then it's not going from an okay study to a brilliant study. It's going from an okay study to a kind of a bit better study.
Each time you're polishing it up.
So the next time it's like, okay, well, we followed people up at 3 months after they had a group intervention for survivors of sexual abuse in childhood or something like that. It's one of the projects that we did. And then it's like, okay, well, we'll run that again, but then we'll follow them up at 6 months and 9 months kind of thing. So, so it's not this kind of massive revolution. It's more like a kind of tweak, do it again kind of thing. And because you've learned and written the first one, it's a bit like the literature and so on, but you're never going from small scale to big scale. You're going from kind of small scale to slightly more internally valid, and you're then on a roll kind of thing. And I always thought that was really helpful, because you kind of build a little bit of expertise as you went along.
Great.
Every now and then you get some really savvy people that come along who might be, quantitatively minded or something like that. And if they are, then. So
have you linked up with folks in the Ivory Tower as well? Did you, or did you manage to do this purely in a kind of NHS setting?
Well, actually, this was all done in Barnsley. So there was. He's called Nigel Beale, worked in learning disabilities. He was a bit like the kind of godfather of this department, and he worked using psychodynamic psychotherapy with people with learning disabilities, but he was a professor, and so he had one foot in academia, so he would feed us I think he was very influential in terms of steering us kind of thing. So, but we didn't have academic partners. We were just interested jobbing clinicians who quite enjoyed that inquiry, the scientist practitioner role, and then getting stuck in. And you do have some false starts, and that's not a bad thing. And you do, but there is something about complete to finisher type stuff that I'm a bit like, I've started it and I've invested in it. There's such a degree of sunk cost, is that
let's get paper out of it. I'm going
to do something with this, because I kind of owe it to myself and the kind of all the patients that have given us the information and the clinicians. So I was a bit of a let's get it over the line type thing. And I'm still a little bit like that. If I've, put some work in, then I want the kind of reward, I suppose.
So one of the things is setting a clear kind of set of objectives and milestones and targets, and actually delivering on those in the same way you would with clinical work, rather than viewing it as a gentleman's hobby to be research active.
Yeah, definitely. And so, but seeing it as not, it's kind of connected. And if you have an identity of, I'm a clinician who does a little bit of research, I'm not a researcher.
Yeah.
I think it kind of lessens the expectations that you've got to do something that's impossible. Do small things quite well, you can normally make a contribution. And that iterative learning process, I think, is really helpful. So in the single case experimental design stuff I've done gradually over the years through getting reviewer feedback and stuff like that, it's like, the next time I do one of these, I need to tweak that, add in that bit. Some new guidelines come out, read those, and then gradually the methodological quality of what you do kind of creeps up over time. So you end up doing something which is kind of it's got all the relevant bells and whistles of a single case experimental design, and that's you think, well, that's like from where I've started to the kind of stuff I do now. You can definitely see a kind of progression there. So for each method, each time you do a project, you can kind of learn from it, and then you don't apply 8 tweaks. You just do 1 tweak, do it again, kind of thing.
Well, you're talking about methodological refinement there, but also what you're doing in that is presumably intervention refinement as you go. So the clinical product's getting really nicely shaped.
Yeah. So if you do if you redevelop something, then reevaluate it. And you've normally got then baseline data to compare it against and things like that. So
You mentioned before we started the interview that actually when you then moved into a slightly more academic job involved in training, you actually were less research productive.
Yeah, which was a bit of a shock, really. So for a couple of years, when I was developing all the IAP stuff and doing a lot of selection, then I was all my time was spent doing that, and that's probably the highest workload I've ever had. And then it kind of settled down, and then it was a case of getting things going again. But of course, then the minimum data set started. And it was like, hold on a minute, all these outcomes are being collected in a routine, in the kind of local routine services. So what are we going to do about that?
So you've set up a kind of, or you're part of an academic hub that properly mines that data for maximum.
Yeah. So science. That is partly one of the ways of everyday jobbing clinicians. So being part of a practice research network, I think, is really helpful, because that's where collaborations kind of form and are maintained, and there's a bit of a kind of reporting back every 6 months on projects, which I think is helpful. So that's been really helpful. But I think that's certainly since my job changed, then the expectations change in terms of the kind of standard of the research and stuff like that. So, but it's still. So I think I've learned more about methodology in the last 10 years than I did I was in the NHS for 13 years, and then I've been in this training post for 10 years. I've learned miles more, but that's just because I'm in a university setting. I talk to people and I go to hear people speak and stuff like that. So the things like learning about dismantling methods, completely naive to those before, have learned those. Learn them. I've become aware of them. And
so is this the CAT trial you ran in an IAP setting?
Yeah.
Where you basically did this dismantling RCT without any funding and got it into a good journal. How on earth did you pull that off?
Well, it was the fact that I thought the idea was really, really clever, and so I was a bit kind of geeked out with the notion that you could do a kind of dismantling bit or an additive bit, and I was always more interested in dismantling than adding something in. And because the therapy has this very distinct intervention that happens about the letter that's written, I was like, okay, that's the point, because it's so, you either write a letter or you don't kind of thing. It's not something that's lost in the alliance. So and it was like, we'll do that, and then that started off as a DClinSci project. So a lot of projects that I've done are DClinSci theses that are then turned into like longer term projects. So the DClinSci might, you develop an idea with them and you might run the project for say 14 months, but it's always set up to run for like 28 months or something like that. So so we're just starting a new project in Ardash, and a trainee clinical psychologist is taking it on as their thesis. And both me and the service and the trainee know that they're going to take the first tranche of the data and write it up to their thesis. And we know that we're going to then run it for double the amount of time, so that we can get enough people that it's a kind of decent study kind of thing.
So there's something about having the slightly longer term view and thinking how you can deliver a student's needs, but also make that part of a larger research.
Yeah. And the really important thing is looking after the student first, and making sure that they have no trip ups kind of thing. And it's because they do all the heavy lifting in terms of ethics and protocols and stuff like that. So it's to make sure that runs, well, nothing runs like clockwork, but it runs okay for them, and there's enough data for them to write up, and they can pass. And then it's a bit, and it's still always their project, even if we run it for longer kind of thing. So it's not taken off them. It's always a collaboration with them as the first author. So
which is a great outcome for that.
Yeah, but it's a nice thing to do. So but again, that's an example of that new project around building a relationship with the trust, and that's very attached to their business plan. So they don't know what to do with some clients in secondary care, and the care coordinators are really struggling with them. So it's a bit like, right, we'll there's been a previous project of a 3-site service evaluation approach, which kind of shows that this consultancy approach is relatively helpful. And then the next progression on is, because one of those studies had some follow-up in it, the next study on is that we've got a passive control, so it's in comparison to a kind of treatment as usual, if you think that's a passive control bit. So, and then it will run for a while, the training will take the data, and then we'll run for a bit longer. And we've got a kind of larger, more robust study, but the service are supportive of it, because the service manager recognises the need, and they don't mind that you're doing
evaluating it properly around the edges.
Yeah, they don't mind that so much, and then I think that's helpful for them. But it's also providing feedback to the service a lot. So I've learned a lot over the last 10 years around, because I was in the service before, it was less of an issue because I meet all the people anyway. Whereas now, more as a kind of external person, it's like the organisational dynamics of it are really important. So there's a study that we're running in Oldham, which is a patient preference trial that we were chatting about before. That is, we've worked really hard at getting like the monthly newsletter about the trial out into all the trust communication. And the trust managers are being very supportive of the study because it's adding kind of kudos to their trust that they're running a patient preference trial in their PWP service. The PWPs are getting a supervision group out of it and learning a new intervention. But it's a bit like that support that goes round the project in terms of the service managers and the overall clinical lead is really important. So having in your project team a kind of communications person.
Well, but it sounds like you've also done quite a careful stakeholder analysis of this is what the trust will need for this to be useful for them to take part in. This is what the student will need for it to meet their training needs. And I can align to those needs and still get some research done.
Yeah. That one's not attached to a student. Though there is a student project embedded in it somewhere about a qualitative bit of it, but that's more part of the practice research network. That the service approached me and said, we've heard about this psychoeducational stuff that you developed, we're interested. And then it's a bit like the dismantling stuff. I've heard something about a patient preference approach and I was like, that sounds really cool, I'll have a go at that. And had a go at it kind of thing.
But it also sounds like it's important you've managed to hang on to actually finding the process enjoyable rather than a horrible set of hoops you have to jump through.
I think it's still some of it's still a horrible set of hoops you have to jump through, but it's the I do still find it enjoyable. I think it's different. When I did it in the NHS, I found it more enjoyable because it wasn't attached to a performance target. Whereas now it's attached to a performance target and it feels more like a kind of relief rather than a source of pleasure. And so for anybody who is a job and clinician to do this stuff feels fantastic. For people who work in academic settings, it's a bit like, that's what you're supposed to be doing. So
why aren't you doing more of it? Bring in more money to do it better.
So it's but it's important to get reward. But that I think that changes over time as well. In that it's more that you help other people to develop their research careers and stuff like that, and you help people to get onto courses. Or you help people to get their qualification or something like that. And I find that really gratifying. And then this kind of adding a small brick to the wall of evidence for something. I'm not adding the foundations or the breeze blocks, but I'm putting a kind of brick in place. And you think, well, that's enough. I'll do it brick by brick.
Well, 100 bricks is half a house.
So, well, it's probably a bit of an extension. So, and that's okay, I think.
So you've given kind of lots of tips along the way, but if someone is primarily a jobbing clinician, not looking to make research the main thing they do, but they'd like to do it as part of their portfolio, any other key bits of advice or suggestions you'd make?
Don't think about it, do it. So if you're interested in like doing something, then I think talking to somebody in university is probably a good idea. But write a protocol of what you want to do and show it to other people, and get people around you, and it is. Some of it's an energy issue, is that you have to have quite a lot of energy to do it, and quite a lot of motivation. And that is, that's a kind of prerequisite. You just have to have that I'm going to do it type approach. And I think I have that. And it's kind of getting it out of my head and it onto paper and then into meetings and stuff like that. And you only do it by crossing the next hurdle. So it's a bit like I never really think of the end point. I just think of the next hurdle. So if the next hurdle is to get like a protocol reviewed by some colleagues, that's what I'll do. If the next hurdle is to get it through ethics, that's what I'll do. I'm never that far ahead. It's just, okay, I'll just do the next bit. And I think that really helps, because if you stand back and see the big picture, it's probably a bit frightening.
It's a bit like running a marathon. If you think at mile 8, I've got another 18 to go, you're not really going to want to do it. If you think I've got to run 500 feet, and then I'll think again.
Yeah. So I think that's quite helpful for clinicians, and something that you're interested in, I think, is really helpful. I think it helps me that I'm interested in loads of things, but it's like, if you're interested in one particular thing and you have that, well, I'll really enjoy this, then I think that really helps. And also, you have to, like when my kids were young, I used to work on Sunday nights and stuff like that. And I never had research time, but I used to do like 3 hours on a Sunday night, because I don't watch a lot of telly, and it was a bit like, okay, so there is some personal sacrifice to that, and maybe that has an impact on the people around you. It's kind of changed as my kids have grown up, but it's so there is that thing around, it doesn't just happen. There's a lot of hours, and you get lost, and you get things wrong, and you can't work it out, and all that type of stuff, and that's okay. But you kind of go back to it. So that kind of growth mindset is kind of quite important, and just you have to slog away sometimes. It's like the payoff is talking at a conference or publishing a paper, but the kind of grunt is a couple of hours on your own, writing stuff or working out how to do stuff, or getting error message after error message from SPSS that you've not, it can't do what you're asking it to do because you've done it wrong. And it's like, oh God. And then you just have to kind of go back to it. So I think since I've started, like, the kind of internet's happened as well. And so often, if I don't know how to do something now, I Google it, and it's on YouTube, and it's like, oh my God, it's just follow the instruction. So that's helpful. And you don't have to use really high-end statistical analysis. That's blue chip stuff. So things like multi-level modelling, machine learning, all that type of stuff, that's full-time research type stuff. I think the type of work that the kind of jobbing clinician can do is things like ANOVA, chi-squares, t-tests, and so on. And that's kind of really good bums on seats research, I think, that was previously kind of blue chip stuff. But I think most people can do that who are fairly quantitatively savvy, and you can get a lot out of that. So being able to, you can look up doing a chi-square on YouTube and it shows you, and it's a bit like, if we've got this many, came back to follow up and this many didn't, it's a bit like, we're going to do a chi-square. So that type of stuff.
So what I'm hearing is growth mindset, quite a lot of grit, and YouTube's your friend.
Definitely.
Okay.
Yeah, great.
Steve, that's really helpful. Thank you very much. I'm going to stop the recording now.